Hey guys, welcome to our presentation on colorectal cancer by Anna, Floriana, Hannah, Emily, Burton, and Joel. What is colorectal cancer? It is a malignant disease of the colon, large intestine, and/or rectum. This is when cells grow and divide abnormally, leading to tumors, either benign or malignant. Just a quick recap of the lower end of the GI tract. Food is digested in the stomach and the large intestine. As nutrients are removed, a watery mass is left and passes through the colon. The colon absorbs the water, and the remaining semi-solid mass passes to the rectum to be excreted. This waste is known as feces or stool. A cancer of the colon or rectum will impede on these processes, altering digestion and excretion. Now we'll discuss some statistics. Colorectal cancer is the third most common cancer in North America, and it is the second most common cause of cancer death in Canada. 1 in 13 Canadian men will develop colorectal cancer during his lifetime, and 1 in 29 will die from it. 1 in 16 Canadian women will develop colorectal cancer during her lifetime, and 1 in 34 will die from it. Considering the graph, note that in 2016, Ontario had the most new cases and most deaths of colorectal cancer among men and women compared to all other provinces. This could, however, be due to the fact that Ontario has the most dense population out of all of the provinces. In 2017, it is estimated that 25,000 people are to be diagnosed with colorectal cancer, with a 5-year relative survival ratios of 65%. On average, 73 Canadians will be diagnosed with colorectal cancer every day. Now on to the pathophys. So most colorectal cancers begin as growths, called polyps, on the inner lining of the colon or the rectum. The chance of it changing into a cancer depends on the kind of polyp. The two main types of polyps are adenomatous polyps, or adenomas. These polyps can sometimes change into cancer. Because of this, adenomas are called a precancerous condition. When they become cancerous, they are called adenocarcinomas. And these are the most common types of colorectal cancer, making up 95% of cases. There are also hyperplastic polyps or inflammatory polyps, and these polyps are more common, but in general they are not precancerous. There is a multi-step process involving the inactivation of a variety of tumor suppressor and DNA repair genes, along with the simultaneous activation of oncogenes. This enables a selective growth advantage to the colonic epithelial cells and drives the transformation of the normal colonic epithelium to an adenomatous polyp to ultimately invasive colorectal cancer. Within the polyp, the cancer progresses down from the tip of the polyp through the body and the stalk. It becomes invasive and penetrates the muscularis mucosae. Once through the muscularis mucosae, tumor cells gain access to the regional lymph nodes and the vascular system and can spread to distant sites. The most common sites of metastasis are the regional lymph nodes, liver, lungs, and peritoneum. Because venous blood leaving the colon and rectum flows through the portal vein and inferior rectal vein, the liver and the lung are the most common sites of metastasis. Cancer spreads from the liver to other sites, including the lungs, bone, and brain. So some risk factors. Age. Your risk of colorectal cancer goes up as you age. Younger adults can get it, but it is much more common after the age of 50. Familial adenomatous polyposis, or FAP, is an inherited disorder characterized by cancer of the large intestine, or the colon, and the rectum. People with the classic type of FAP begin to develop multiple non-cancerous benign growths, or polyps, in the colon as early as their teenage years. Unless the colon is removed, these polyps will become malignant. A personal or family history of polyps in the colon, rectum, or both significantly increases the risk of developing colorectal cancer. People with irritable bowel disease are also at an increased risk of developing colorectal cancers. A family history of colorectal cancer, and women who have had breast cancer, ovarian, or uterine cancer have an increased risk of developing colorectal cancer. A diet high in red meat, such as beef, pork, lamb, and goat, and processed meats, which are meats preserved by smoking, curing, salting, or adding preservatives such as nitrates or nitrites, increase the risk of developing colorectal cancer. Colorectal cancer also occurs more often in people who are obese or overweight. Now on to some clinical manifestations. Clinical manifestations include changes in your bowel habits, such as constipation and diarrhea, or alternating between the two, rectal bleeding or blood in your stool, abdominal bloating, cramps, or discomfort, a feeling that your bowel doesn't empty completely, stools that are thinner than normal, unexplained weight loss, unexplained loss of appetite, nausea and vomiting, anemia and jaundice, and weakness or fatigue. Oh no, we'll go to this one. Clinical manifestations of colorectal cancer are usually nonspecific and do not appear until the disease is advanced. Rectal bleeding, the most common symptom of colorectal cancer, is most often seen with left-sided lesions. Other commonly seen manifestations of left-sided lesions include alternating constipation and diarrhea, change in stool caliber, and the sensation of incomplete evacuation. Obstructive symptoms appear early with left-sided lesions because of the smaller lumen size. Cancers of the right side of the colon are usually asymptomatic. Vague abdominal cramping or discomfort, colicky abdominal pain may be present. Iron deficiency anemia and occult bleeding dictate further investigation, and the weakness and fatigue will result from anemia. So, some diagnostic tests. Family history is an important part of diagnosis. Risk factors mentioned previously should be noted and screened for. A digital rectal exam, commonly called a prostate exam, is where a physician inserts a lubricated finger into the rectum. 20% of colorectal cancers can be felt upon this exam. Sigmoidoscopy and colonoscopy could also be performed. 50% of colorectal cancers can be seen by a sigmoidoscopy. Tissue diagnosis may be made by a biopsy during these procedures. A barium enema is an X-ray exam that can detect changes or abnormalities in the large intestine. A complete blood count may be performed to check for anemia and to look at clotting studies. These are performed as colorectal cancer has a high chance of bleeding. Liver function tests are performed to determine if liver metastasis has developed. Fecal occult blood tests are performed as it is common for colorectal cancers to bleed. Carcinoembryonic antigen test, or CEA, is actually not a test that is specific to colorectal cancer. It is used most effectively to see if a tumor was removed during surgery, as the levels would return to normal if it was effectively removed. A CT scan of the abdomen can be performed to localize the lesion and determine the size or presence of metastases. Computerized tomography colonoscope combines helical CT scans to produce 2D and 3D images of the colon. Ultrasounds are also used to localize the lesions and determine its size or the presence of metastases. So, staging colorectal cancer using the TMN classification. When this is done, the T refers to the tumor itself. N refers to the infiltration to the lymph nodes, and M refers to the metastases in different organs. The type of treatment chosen depends on the stage of the cancer as well as the location. The patient's overall health and preferences are also considered. So, treating colorectal cancer. Endoscopic polypectomy is the removal of colorectal polyps. The resected margin of the polyp is cancer-free. This treatment is highly effective if the cancer is well differentiated and there is no blood vessel involvement. Laser treatment is used to ablate unresectable tumors. It is used to remove colon polyps or tumors that are blocking the colon. This treatment is usually only used as a palliative therapy in patients with obstructive symptoms. Surgery is the only curative treatment for colorectal cancer. A right hemicolectomy is the removal of a portion of the terminal ileum, the ileocecal valve, and the appendix, and an iliotransverse anastomosis. The small intestine is then attached to the remaining colon. A left hemicolectomy is the resection of the left transverse colon, the splenic flexure, the descending colon, and the sigmoid colon, and the upper portion of the rectum. The remaining sections of the colon are reattached. Abdominal perineal resection is performed when the cancer is located within 5 centimeters of the anus, although ultra-low anterior resections can be performed within 1 to 2 centimeters of the anus. The distal colon, rectum, and anal sphincter are completely removed through a perineal incision. The sigmoid is brought through the wall as a permanent colostomy. Complications that can arise from this procedure are delayed wound healing, hemorrhage, persistent perineal sinus tracts, infections, and urinary tract and sexual dysfunction. Low anterior resection is performed on those with tumors of the rectosigmoid and the mid to upper rectum. A section of the rectum and/or lower sigmoid is removed. The colon is attached to the remaining rectum to allow for usual bowel movement. Sphincter sparing procedures are being used more often now when it is possible. They are performed on a patient with a poor operative risk and are in an early stage of the disease process. The local section of the colon is removed and the anal sphincter is left in place. Laparoscopic colectomy is a minimally invasive colectomy. 3 to 5 small incisions are made in the abdomen and the colon is removed through the abdomen. Chemotherapy can be used when the lymph nodes are positive for cancer or the cancer has metastasized. Chemo can be used as an additional therapy with surgery, or it can be the primary treatment. Radiation therapy to the abdomen, pelvis, bone, or brain may be used as palliative therapy for advanced colorectal cancer that can't be removed with surgery. Biological agents used in treatment are known as targeted treatment. It is used to treat stage 4 cancer that has metastasized. 2 examples of this type of treatment are Erbitux and Avastin. Erbitux inhibits the epidermal growth factor receptor, which inhibits the cancerous cells from growing and multiplying. Avastin binds to the vascular endothelial growth factor, thereby inhibiting angiogenesis. These are both indicated for colorectal cancer. So some complications. There are several complications associated with bowel cancer. The first few are a result from treatment. Infection and pain may occur after surgery. Vigilant infection control protocols must be maintained as patients with a low immune systems are more susceptible to infections. Also, nausea, vomiting, diarrhea, and immunosuppression are a direct result of chemotherapy. Cancer cells that break away from the primary tumor and travel in the bloodstream or lymph system to other parts of the body cause metastases. These new sites of disease are still colon cancer, even when they're in other organs of the body. Metastasis in colon cancer is usually seen in the lungs, bone, and liver, but it may occur in other sites as well. The third complication, bowel obstruction, occurs when feces are unable to move through the intestine. Causes include mechanical blockage, such as adhesions from surgery or a growing tumor. Abdominal surgery can lead to paralytic ileus, where no mechanical block exists, but the intestines are unable to contract and relax. Polyps in colon cancer can cause a slow, steady bleeding into the colon. This can manifest as melena. Bleeding may also be due to surgery. A fistula is an abnormal opening between organs or other structures in the body. Damaged or inflamed tissue that come in contact with other tissue can fuse together abnormally during healing. Cancers can cause fistulas by causing erosion of the epithelial layer. For example, if a colon cancer is left in place, there is the potential of it creating a hole as the tumor gets bigger. Sometimes complications from surgery or healing after surgery can also result in fistula formation. The last three complications are related. A bowel perforation is a hole in the wall of the small intestine or the colon. Food, digestive juices, bacteria, or waste-like stool can leak from the hole into the intestine, and this can lead to an abscess. When the contents of the intestine leak into the peritoneal cavity, it can lead to peritonitis, which is inflammation of the outer membrane covering the abdominal organs. If the infection enters the blood, it can result in sepsis and septic shock. So next on to the nursing management. So in the assessment phase, we're looking at the subjective data from our patient. So we're going to ask questions about their past health history. This is where we're asking our patient about those risk factors mentioned earlier. So FAP, do they have a past history of FAP, a family history of colorectal cancer, breast or ovarian cancer, and do they have something like inflammatory bowel disease? Are they using any medication that affects bowel function, such as cathartics or antidiarrheal agents? Are they having symptoms such as weakness, fatigue, anorexia, weight loss, nausea and vomiting, change in bowel habits, rectal bleeding, decrease in stool caliber, feelings of incomplete evacuation, or abdominal and lower back pain? Objective data. Are we seeing or feeling any of these? Pallor or lymphadenopathy, which is a later sign. Abdominal distension or a palpable abdominal mass, which is also a later sign. Hepatomegaly or elevated liver function tests, which would be a sign of liver metastasis. Next, for the planning and goals. We want the appropriate treatment, we want normal bowel elimination, we want relief of pain, and to improve quality of life and feelings of comfort and well-being. Implementation. Implementation consists of health promotion, pre- and post-op care for someone who's undergone surgery, and home care. Health promotion. The current recommendations from the Colorectal Cancer Association of Canada for colorectal cancer screening in patients who are not at a high risk include fecal occult blood testing or fecal immunochemistry testing performed every 1 to 2 years, starting at the age of 50. Positive findings should be followed with a flexible sigmoidoscopy, colonoscopy, or double contrast barium enema. Screening for high-risk patients should begin before the age of 20, usually beginning with colonoscopy continuing at more frequent intervals that vary according to risk factors. Participation in early cancer screening is effective in decreasing mortality. Pre-op care. In addition to the general preoperative teaching and ostomy care instructions, the patient undergoing an abdominal perineal resection should be informed of the extent of the surgical procedure and the potential for sexual dysfunction after the surgery. Comfortable positioning may be difficult with either an open or closed perineal wound. The patient may experience phantom rectal sensation because the sympathetic nerves responsible for rectal control are not severed during the surgery. The nurse must be aware in distinguishing phantom sensations from perineal abscess pain. Post-op care. After an abdominal perineal resection, there are 2 wounds plus a stoma that is surgically constructed in the left lower quadrant. There is an abdominal incision through which the colon is resected, and an incision is made in the perineum. As nurses, we need to be aware and on top of pain management and wound care. We should examine the wounds regularly and record bleeding, excessive drainage, and unusual odor, and observe for signs of induration, erythema, plurulent drainage around the suture line, fever, and elevated white blood cell count. A JP, or hemovac drains, are usually present to provide drainage at the operative site. Drains usually remain in drainage until there is less than 50 mL in a day draining. Drains should be assessed for the amount, color, and consistency. Ambulatory and home care. An open perineal wound may not be completely healed before discharge. After discharge, a home health nurse usually sees the patient. The patient and significant others may be taught assessment and management of the wound. The patient and the family should be aware of all community services available for assistance. Psychological support for the patient and the family is important. The overall 5-year survival rate for all patients undergoing resection for colorectal cancer is less than 50%. This is often attributed to the painful and debilitating manifestations produced by the recurrent disease. And finally, for our evaluation, we want our patient to have regular bowel elimination patterns. Our patient will have relief of pain, will have a balanced nutritional intake, and will have feelings of comfort and well-being. Next, we'll be addressing collaborative care for patients with colorectal cancer. A multidisciplinary team is a model that involves various specialists with a patient-centered approach at its core. The interdisciplinary professionals work together to identify tests and treatment options for the patient to consider and choose. Professions that make up this team can include surgeons, oncologists, radiologists, pathologists, nurse, nutritionists, and a cancer coordinator. Several important patient benefits have been reported for patients under the care of a multidisciplinary team. These include better accuracy of disease staging, fewer treatment and referral delays, better clinical and survival outcomes, enhanced quality of life, and enhanced continuity of care. Moving on to communication between members of the healthcare team and patients. Care for patients with colorectal cancer requires effective collaboration and communication between all healthcare providers. Camrad et al. In 2015 reported that the involvement of general practitioners in cancer care is lacking. Furthermore, they concluded that communication among general practitioners, specialists, and other healthcare providers in cancer care has been found to both positively and negatively influence quality of care experienced by patients. Specifically, it was found that insufficient collaboration, communication, and transfer of information was impacting quality of care. To rectify problems in the coordination of care among healthcare providers, three important themes arose from the experiences of patients with cancer. These were the consideration of all healthcare providers, efficient exchange of information among healthcare providers, and a focus on the entire process of care. Therefore, studies have shown that in regards to their care, patients believe good communication between healthcare providers is essential to improving their care. Patients also want their healthcare providers to listen to their concerns, explain results, findings, and options, be approachable, and be accessible. Patients also express the need to be treated with respect, be kept informed, and be active members of their own care. As agents of their own care, findings have shown that cancer patients often struggle with the complexity of their disease and their care, leading the concern for self-management. Patients with colorectal cancers are challenged by and have to handle complex situations with respect to the disease process. Challenges include side effects of the disease and treatments, practical problems such as changing ostomy bags, and comorbidities that they experience. Nurses can help patients by supporting interventions for self-management. O's et al. 2017 identified 3 self-management strategies that emerged among patients with colorectal cancer. Proactive behavior included strategies such as preparing for visits, searching for information on their own, and organizing their own care. Proactive demanding was represented as seeking support and guidance, as well as engaging in meaningful tasks with their doctor. Lastly, proactive data management entailed patients merging data from their treatment and collecting documents that they have received in the process of their care. The cornerstone of these strategies is that They all require the patient to be proactive and autonomous when it comes to their care. And now a case study to review. Martha is a 67-year-old female who comes to visit her primary care nurse because she has had intermittent diarrhea and constipation with some abdominal pain for the past 2 months. What are some questions that you might ask her? She has had weight loss of about 6 kilograms over 2 months. She feels more tired than normal in the last month. Her diet is lacking fiber and is low in fruits and vegetables. There is no history of cancer in her family, no previous medical conditions, and no previous surgeries. She's been married for 35 years and has 2 children. She has no history of smoking or alcohol abuse. You take her vital signs, and they are as such. Temperature is 37 degrees Celsius, pulse is 75 beats per minute, blood pressure is 130/80, and respiratory rate is 14 with oxygen saturation at 100% on room air. Given her age, what are some forms of pathology that might be suspected? What sort of screening and laboratory values would we need? We would suspect colon cancer. We would also suspect anemia secondary to either a GI bleed or iron deficiency. A change in bowel habits with or without abdominal pain is the most common symptom, although asymptomatic colorectal cancer is common. Signs and symptoms of anemia and blood in the stool are also common. Right-sided lesions present with anemia from occult blood, and left-sided present with constipation and red blood in stools. Rectal lesions are also present with bright red fresh blood and cramping rectal pain. A CBC panel would be needed to determine anemia status. Iron and vitamin B12 would be needed to determine the source of anemia. Fecal immunochemical test or fecal occult blood testing to determine if there is blood in the stool and a white blood cell count to rule out infection. We would do urinalysis and liver function tests and the CEA test as well. The gold standard for screening for colorectal cancer is a colonoscopy. The cancer would be staged with a contrast CT of the abdomen and a colonoscopy. For rectal cancer, a pelvic MRI and/or endorectal ultrasound may also be ordered for staging. Surgical resection is the standard treatment with chemotherapy and/or radiation. What are some of the goals the nurse and the patient may have moving forward? We want to normalize bowel elimination as much as possible, maintain our patient's quality of life, offer pain relief, maintain a sense of well-being and comfort, and ensure adequate nutritional and fluid intake. What are some of the acute interventions, implementations expected post-surgery? So post-operatively, we want to monitor electrolytes, take vital signs, and monitor fluids, look for abdominal distension, gas pain, and monitor for bowel sounds. Nausea and vomiting would be managed with antiemetics such as ondansetron. We assess for pain and manage with pain medication, wound and/or ostomy care, which includes access drainage, color of the wound, and sutures. And this also includes patient teaching for wound care and/or ostomy care. We want to teach about bowel elimination and continence care, so patient teaching for continence and management of diarrhea and constipation. And we also want to offer psychological and emotional support for the patient and their caregiver. Thank you guys so much for watching. We hope you enjoyed.